Pooja.
Hello.
Yeah, Dr. Pooja.
Yeah, yes, sir.
Yeah, I'm Dr. Shivayogi. I'm one of the judge for this session.
Yes, sir.
If you are free, you can present your paper.
Yes,
Can you speak little louder?
can you hear me now, sir?
Yeah, little louder. Huh? You go
Yes,
ahead with
sir.
your
Yes, sir.
presentation. So you're going to present ophthalmic manifestation in patient.
No, sir. Mine is.
Popping eye,
Yes, sir.
popping eye gets different.
Yes, sir. Yes, sir.
Yeah. Ravi, are you audible now?
Yeah.
Okay then. Shall we start this session, Dr. Ravi?
Yes. Shivaji,
Shivaji is online.
Unmute.
Start.
Yeah. Shivaji, Dr. Ravi, and Dr. Shivayogi are judges for this session. Yeah, you
Yes.
can start now, Dr. Pooja.
Yes, sir. Can you see my screen, sir?
Yeah. Quite
Yes.
well.
Yes. Here is a study. I'm presenting my study, which is a popping eye and its differential diagnosis. The unique ID is FP849, section of oculoplasty. The chief author being Dr. Shriprata Hegde, and presenting author being me, Dr. Pooja Sukumar. Introduction. Proptosis or exophthalmosis is abnormal protrusion of the eyeball. 2 mm or greater asymmetry is considered abnormal. It presents with no symptoms or with symptoms like pain, redness, proptosis, eye discoloration, restriction of movements. Etiology can be benign to life-threatening. Common etiologies being infectious, orbital inflammatory, vascular, tumors and malignancies, and pseudoproptosis. Objectives of my study was to study the etiology of unilateral proptosis and the demographic characteristics, signs and symptoms. The materials and methods in this, this was a study conducted over a period of 1 year. It was a prospective observational study. In this study, we've studied all, noted all the patients which have presented in the OPD or in the inpatient department with unilateral proptosis and studied the detailed history, clinical symptoms, and investigations were done. The results of our study. In our study, the patients ranged from a wide range age group of 6 years to 75 years, and most of the patients were above the age of 40. 55.3 of the patients were males, and minimum proptosis of 2 mm was noted, while a maximum proptosis of 18 mm was also noted above the normal. Axial proptosis was the most common cause in our study, which was accounting up to 74.4%. Infectious pathology in that was the most common pathology, which was 82.9%. Tumors and malignancies being next, accounting to 14.8%, and inflammatory pathology of 7.5%. Owing to the COVID era, orbital mucormycosis was the most common cause in my study, accounting to 57.4%. The patients presented with proptosis of the eye with pain and swelling, and eschar in the nasal mucosa and hard palate. Orbital cellulitis was also noted among 7 patients. The first picture, you can see a small boy of 10-year-old who was presented with orbital cellulitis and admitted in the PICU. We had given IV antibiotics and the patient recovered over a period of 4 weeks. On the left, you can see an adult patient which also presented with orbital cellulitis with extensive chemosis and fullness of the eyelid. This was a 8-year-old boy which presented with chemosis and swelling of the right eyeball. On examination, we did CT scan for the patient, and we found that near the lateral rectus, orbital abscess was noted. We gave IV antibiotics. The abscess was regressed with IV antibiotics, so we continued giving IV antibiotics and didn't go for incision and drainage for this particular patient. Below, you can see a patient which presented with redness in their eye. She was a 52-year-old woman who just presented with redness in her eye. And on examination, we noted a 3 mm proptosis of the left eye. We did CT scan. The radiologist suspected superior ophthalmic vein thrombosis and did a CT angiography to confirm superior ophthalmic vein thrombosis. And later on, the patient was referred to a neurologist for endovascular embolization. Here we can see two different kinds of mucosal presentation was noted in my study. The first photograph is of a 52-year-old woman who again presented with a pain in the right eye. She did not complain of proptosis at all. On examination, we noted that she had about 6 mm of proptosis, and we were suspecting thyroid orbitopathy. So we sent her for a thyroid profile, which turned out to be normal. Later on, when we did CT imaging, we noted that there was a frontoethmoidal mucosal, which was abutting the, invading the orbit, and it was also abutting the optic nerve. Luckily, her vision was not compromised. In the left, you can see another patient she initially presented with maxillary area or left cheek fullness, which she had maxillary sinus mucosal, which was resected by a ENT doctor. But the patient, after over the period of 5 years, recurred with mucosal. And this time it was quite extensive, and it had intracranial extension, and it also extensively involved the orbit, which caused extensive axial proptosis of about 11 mm in this particular patient, and the optic nerves compressed, and so the patient lost vision completely in that eye. Below, you can see a 7-year-old girl who presented with fullness of the right cheek and proptosis of the right eye. On examination, you can see in the USG examination, ill-defined solid cystic lesion was noted. The patient was given sclerotherapy by bleomycin, and later on the malformation did not regress. So we had gone for excision by a pediatric surgeon. Inflammatory etiology. This patient is a 52-year-old woman who presented with fullness in the left eye and redness and swelling. On examination, we noted 2 mm of proptosis in the left eye. And on CT imaging, you can see that the superior lid, there is a lesion noted. We gave steroids, and the patient recovered in the next 3 weeks. Below, you can see two different cases of thyroid orbitopathy. Thyroid orbitopathy presenting with unilateral proptosis. Tumors and malignancy. On the left, you can see a 27-year-old woman who presented with fullness in the left, in the right eyelid, and also proptosis in the right eyeball of 3 mm. On CT imaging, intraosseous lipoma was noted, and by taking reference from the neurosurgeon, the patient was asked to leave the lesion alone, as it was not causing any problem to the vision. In the left, in the right, you can see a malignant melanoma of the right eye, which was extensive, and this was a 72-year-old woman. So again, excision was tried for the conjunctival area later on, but it was too extensive, so further treatment was not done. Here is a patient of neurofibroma, a 38-year-old male patient presented with neurofibroma. He was already diagnosed with neurofibroma when he presented to us, and it caused again axial proptosis of 12 mm in the left eyeball. We also had a 52-year-old male patient who presented with proptosis of the left eyeball. On CT imaging, you can see the lesion, which is right behind the globe in the right side, and the tumor was pressing on the eyeball so much that it was causing choroidal folds. We had two cases of metastasis in our study. One patient presented with temporal lobe intracranial extension, which caused proptosis of the right eye and fullness of the right eyelid. And the patient presented to us with just swelling of the right eye. On examination, exposure keratopathy was noted, with which later on developed a corneal ulcer, and it was treated for the same. But there was nothing was done to the lesion because it was too extensive. Below is a 28-year-old male patient who presented with extensive metastasis of in the maxillary region, nasal cavity, left orbit, and the intracranial extension of esthesioneuroblastoma. neuroblastoma. We had 3 cases of pseudoproptosis too. The first photo being of ophthalmus. The second one is a woman again presented with ophthalmus. Since it was a blind eye, the patient also developed spheroidal degeneration. And on the left, on the right, you can see a unilateral myopia patient with high axial length. Discussion. A study done by Susan D'Souza, a clinical profile of unilateral proptosis in a tertiary care center, showed 32% of the patients had inflammatory etiology, followed by neoplastic lesion in which squamous cell carcinoma was the most common cause of accounting to 12% of the cases, followed by pseudotumors 8%. A study done by Chandana Chakrabarti showed that profile of proptosis in a tertiary care hospital, where non-axial proptosis was the most common cause and neoplasia was the most common etiology, accounting to 41.9%, followed by thyroid orbit ophthalmopathy. Conclusion: a proptosis, however small the bulge, malignancy should be ruled out, and it requires collaboration with other specialties like ENT and radiology, sometimes neurosurgeon and pediatric surgeons. Malignancy is the most common cause in the other studies, but in our study, it showed infectious origin was the most common cause noted. No financial disclosure. Thank you.
Yeah, that was a nice presentation, Dr. Pooja. Can I ask you from which institute you come?
So, Mysore Medical College, sir.
Yeah, it's great if postgraduates get exposed to such an array of oculoplasty diseases.
Yes, sir.
It's a good study. That is a good study. Really appreciated.
Yes, sir.
I would like to know, I have a couple of questions.
Yes, sir.
So number one is, see, this is an era of COVID.
Yes, sir.
So if you ask me which is the most common cause for unilateral or bilateral proptosis, I would always say it is COVID-19 related mucormycosis.
Yes, sir.
In this era. But
Yes,
apart
sir.
from that, which is the most common cause for unilateral and bilateral proptosis?
So in my study, orbital cellulitis was the most common cause, sir.
Apart
Ranging
from your
from
study,
yes, sir.
do you have any
Sir,
idea of which
in
is the most
general,
common?
neoplasia was found out to be the most common cause,
No,
sir.
no. It is the thyroid eye disease.
Thyroid eye disease.
Yes,
Yes.
thyroid eye disease is still the most common cause for unilateral as well as bilateral proptosis or exophthalmos, whatever it is.
Okay.
So exophthalmos we restrict to the thyroid eye disease. Proptosis is other than thyroid eye disease,
Yes.
isn't it?
Yes, sir.
And in your study, there is one boy who had a abscess in the lateral.
Yes, sir.
orbit.
Yes, sir.
So if I ask you in general, which is the most common site to have an orbital abscess in pediatric age? Is it the lateral orbit, superior orbit, inferior orbit, or the medial orbit? That is the medial orbit, right? Because they usually have the ethmoidal sinusitis, and through
yes.
the sinusitis, they will have the orbital cellulitis of the medial wall of the orbit, and it's quite obvious and most common region is the medial and the superomedial aspect of the orbit, where usually we put an incision to evacuate the pus.
Yes.
Yeah. Right. Anyway, good study. Congratulations. We will go to the next.
Thank you so much, sir.
Who is presenting next talk?
Dr. Aparna, are you there?
Yes, ma'am.
Yeah, Dr. Aparna, your study is on a study of frequencies of CRAO in post-COVID-19 rhino-orbital mucormycosis.
Yes, sir.
Go ahead.
So my study is frequency of central retinal artery occlusion in post-COVID-19 mucormycosis. My chief author is Dr. Reshma Ravindra. Introduction: mucormycosis or zygomatic is a fungal infection caused by zygomycetes. Infection with the Mucorrhizaceae family of fungi is the most common, hence many investigators use the term abdominal pain, bloody vomit, and possibly altered mental status. It is a life-threatening decision in immunocompromised patients because of diabetic ketoacidosis, neutropenia, organ transplantation, and or increase in level of available iron. Patients infected with COVID-19 have elevated levels of fibrinogen and D-dimer levels and a mild prolongation of PT-APTT, which leads to increase in the risk of coagulopathy, thereby causing arterial thrombosis. COVID-19 also causes endothelial dysfunction due to inflammation-induced hemostasis and creates a procoagulant state with multi-organ involvement. These factors are established risk factors for retinal artery occlusion. CRO and mucormycosis, the pathogenesis is there is direct invasion of vessels by fungal hyphae, which causes thrombosis and occlusive vasculitis. This leads to CRO. Even though it is not possible to certainly say that there is an association between CRO and mucormycosis in post-COVID-19 patients, we have to consider the correlation as reasonable. The objectives of my study were to understand the prevalence of CRO in rhino-orbital mucormycosis. Methods and materials. The study was conducted between 1st April 2021 to September 1st, 2021 after obtaining approval from Institutional Ethics Committee in RLJS attached to Sri Devraj Ars Medical College, Tamka, Kolar. A detailed history of
We
Poor
have lost
connection,
the
I think.
audio. Audio is lost. Is it audible to other judges?
No,
The audio is
No, it's
lost,
not.
madam.
Dr. Aparna, can you please check your internet connection once? Hello.
Yeah.
hello.
Now
Dr.
it's audible.
Aparna, you are not audible.
Now am I audible?
Yes.
Yeah, yeah. Now it's okay. Fine.
Okay.
Go ahead.
The inclusion criteria were in patients previously hospitalized for COVID-19 treatment was diagnosed with rhino-orbital mucormycosis, a lab-confirmed case of mucormycosis either by QH culture or histopath. The exclusion criteria were patients admitted in mucormycosis ward who have been diagnosed clinically not mucor on DNA, that is diagnostic nasal endoscopy, patients admitted in mucormycosis ward whose MRI and CT suggested paranasal sinusitis but QH negative for mucormycosis, and patients who do not consent for the study. The results, 34 patients were included in the study, out of which 25 were males. 27 out of the 34 patients were COVID positive, 10 were diagnosed with CRO, and 1 patient had intracranial extension. Out of 25 males of rhino-orbital mucormycosis, 9 were found to have central retinal artery occlusion, and 9 females who had rhino-orbital mucormycosis, 1 had CRO. Totally, out of 34 patients of rhino-orbital mucormycosis, 10 patients were found to have central retinal artery occlusion. So the prevalence rate was found to be 29.11%. The discussion. CRO is an ischemia of the inner layers of retina. The classic signs of CRO includes painless loss of vision, a relative afferent pupillary defect, and fundoscopic findings indicative of retinal hypoperfusion. The frequency of CRO is 29.11% in post-COVID rhino-orbital mucormycosis as per the study conducted in the tertiary care center in Kolar district of Karnataka. Conclusion, we are learning more about the new and long-term manifestations of COVID-19 infection. Its association with invasive mucormycosis is dangerous and must be given serious consideration. It is likely that COVID-19 patients could be at risk of developing retinal vascular occlusions. A detailed ophthalmological surveillance is thus advisable to prevent and manage this cause of severe irreversible vision loss. Thank you.
Thank you, Aparna. That was a significant number, isn't it? Nearly 30% of patients losing their vision because of CRO. How many patients of CRO you have seen in your institute yourself?
Sir, yes, sir, out of 10, first visit I gave were 5. So out of all the 10,
Have
all
you
the
seen
5,
their fundus?
yes, sir. And all the 10, after it was confirmed by somebody else, I saw all the 10 cases, sir.
You've seen all the 10 cases.
Yes, sir.
Can you make any difference between a normal CRO and CRO-related COVID-19 cases in your study? Was it same like other CROs?
No, sir, it was almost the same, sir.
It was almost the same in your study. Okay. Can you give me some reasons for the mucormycosis in COVID-19? Why there was an endemic of mucormycosis?
Sir, first of all, the COVID-19 patients, they were given steroids, so their immunity was compromised, and many of the patients on top of that were diabetic. So, immunocompromised, the patient status were immunocompromised. So,
One
and
was,
oxygen,
one was
inhalational
steroid usage. Yeah.
steroid diabetes also one of the cause, sir.
Mhm.
And oxygen was given to inhalational oxygen was given. That was also one of the causes.
Do you think that means we were not giving steroids earlier in any other diseases like arthritis, spondylitis? We used to give high dose steroids for many days. Why in COVID era we are seeing so many mucormycosis?
Sir, their immunity was already low because of COVID-19.
Mhm.
So probably this is one of the more reasons adding to the status of the patient.
Okay. See, there are not much evidence-based study for this. We need to evaluate. There are many causes. The one cause which has been seriously talked about is the virus itself damaging the pancreas.
Okay, sir.
The other causes, like what you told, like humidifiers or contaminated oxygen, whatever, they are still in study. They're in research. They have not come up with any clear point. The one which they stress is the direct damage by this delta strain of COVID-19 to the pancreas, damaging the islets of Langerhans. That they recently they are coming up with.
Okay, sir. Yes, sir.
They are all contributory steroids,
Yes, sir.
and this oxygen, whatever. They are all contributory factors. Immunity, low immunity.
Yes, sir.
Thank you. Any other questions from other judges? Dr. Ravi and Dr. Shivaji.
No, we can go ahead. Next.
Shall we go to next paper?
Yeah.
Dr. Varshita, are you there?
Stop screen sharing. Parada.
Hello.
Parada has to stop screen sharing. Exit.
Dr. Neelima, are you there? Dr. Neelima?
Yeah, yes, ma'am. Yes, ma'am.
Okay, are you ready?
Nilima is going to present
Yeah, ma'am.
Okay.
cellulitis lesions, evaluation and management. Go ahead. Dr. Nilima.
Yeah, just a minute, sir. I'm just sharing the screen.
Okay.
Now, sir.
Yeah. Go ahead.
Yes, sir. Good afternoon, everyone. Sir, my topic is preseptal and orbital cellulitis in infants, evaluation and management. So, introduction, we are just presenting a case, two cases and
Make it full
outcomes.
screen.
Yeah, sir, I have made it full screen. Can you see it as a full screen?
No. I think you have not made it full screen. Slides are visible at my. Okay, go ahead.
Yes, sir. So the pediatric preseptal and orbital cellulitis is rare, but it is a high potential to cause loss of vision and even a threat to life. So it occurs mainly due to spread of infection from periorbital structures, including the eyelids or any facial cellulitis or dental abscesses.
Nilima,
Yes,
sorry
sir.
to interrupt you. Your paper is in infants or in children?
Infants, sir.
Infants.
Like within 1 year, sir. Two cases, case reports
Less
of.
than 1 year you're talking
Yes,
about.
yeah, 1 year. The children which we did a study was in 1 year.
Okay.
So the most commonly the spread is from sinusitis, and among them the ethmoidal sinuses are the most common source. So here we present two cases with two infants presented with preseptal and orbital cellulitis. So coming to case one, present 1-year-old male child from Bellary. He presented with fever and running nose for 1 week duration, and he also had cough and difficulty in breathing. Which was for 2 days, and swelling around both the eyes for 2 days.
Go to the slide now. Go to the slide and explain.
Sir, I think it's not getting shared properly because it's coming here.
No, now it is coming. Yeah.
Ah,
You can change.
Now, sir?
Yeah, it has
Okay,
come.
sir.
You go to the picture of the patient.
Yes, sir. So the swelling of the right eye. So right eyelid was presented first, followed by swelling around the left eyelid.
No, go to the 6th slide where you have the picture. Ah, yes. Yeah. Tell me now.
Yes. So the child came with history of fever, running nose, difficulty in breathing, and also swelling around the eyes for 2 days duration. So the swelling started around the right eye, followed by it progressed to the left eye also. So there was lid edema and erythema, and the child was on a general examination. Child was febrile and irritable. On local examination, there was lid edema in both eyes, more in the right eye. So there was difficulty in opening the eyelids. There was a conjunctival congestion in the both eye. So the pupillary anterior segment and pupillary reaction was okay. Pupils are reacting 3 millimeter brisk and cornea was clear. There was no conjunctival chemosis and movement restriction was not elicited properly because the child was very irritable. So we had started on IV antibiotics on admission, and we did a CT scan. CT PNS and orbit was done, which showed a right-sided orbital cellulitis. So there was a soft tissue edema in the right eye, and after the CT report, we had we got a ENT opinion because
You
of
have, the CT scan picture.
yes, sir. Bilateral ethmoid and maxillary sinusitis. So
Shall we see that?
yes, sir. So there was bilateral ethmoid and ethmoid sinusitis, and yeah, there was maxillary sinusitis. It's not clear in this picture. So in view of the sinusitis, we had taken an ENT opinion also, and they had posted the child for functional sinus endoscopic surgery under general anesthesia, and sinuses were cleared. So they could identify mucosal mucopurulent collection in the ethmoidal sinuses. So they had that ethmoidectomy with the sinus clearances. And following the surgery, the child showed a drastic improvement with a decrease in the fever spikes, also a resolution of the lid edema. So the culture of the swab, there was methicillin sensitive Staph aureus was grown in the culture of this child. So methicillin sensitive Staph aureus was grown in the culture. So the child was started on IV antibiotics. We had started on augmentin initially, which was added on with amikacin and metronidazole. And after 10 days of IV antibiotics, child was discharged on oral antibiotics, and child was stable hemodynamically and with resolved periorbital edema during the time of discharge. So this was the first case, and this is the child at the time of discharge.
Yeah, the other
So
case.
coming to the second case, sir, it is a 1-year-old female child from Koramangala, Bangalore, with history of fever, nasal discharge for 1 day, and swelling around the left eye for 1 day duration. So the lid swelling was confined to the left lower eyelid initially, but which progressed to involve the left upper eyelid also. And the swelling was also noted in the left side of face and also involving the left nasal bridge. And soon after, at the time of admission, the parents noticed there was a nasal discharge which was serosanguinous in nature. So we had did a CT PNS and orbit for this child also. So this is the child at the time of admission. So she had swelling mostly in the left lower lid and which had progressed to the left upper lid also. and serosanguinous nasal discharge and left nasal bridge swelling also was noted. So CT showed mucosal thickening in the left. There was bilateral maxillary and ethmoidal sinusitis. Along with that, there was a mucosal thickening in the left nasal cavity with edema and collection in the nasal ala. So, and the features were suggestive of left preseptal cellulitis. So, in view of the sinusitis, ethmoidal and maxillary sinusitis, ENT opinion was taken, and also the left soft tissue edema, like left-sided nasal soft tissue edema. The child was taken up for FES immediately under general anesthesia. And there was also their ethmoidal sinuses were full with mucopurulent discharge, and the sinuses were cleared. So ethmoidectomy, inferior turbinectomy was carried out. And soon after the following the surgery, this child, female child, also showed a very drastic improvement compared to the other child. And we started on IV antibiotics. The nasal swab and pus culture showed methicillin-resistant Staph aureus growth, which was heavy, and started on triple antibiotics like IV ceftriaxone, amikacin, and metrogyl. Child was discharged after 10 days. We sent her on oral antibiotics and topical antibiotics, and she was looking well on during the time of discharge and also during the follow-ups. This was during the time of discharge. So the discussion mainly includes the early evaluation of children with or mainly infants with preseptal and orbital cellulitis is very necessary. So in order to know the source of infection and to find out the source of infection, so that we can treat accordingly, and it can help in the early resolution of symptoms. So the main thing is early imaging and in the surgical intervention in infants with preseptal and orbital cellulitis can prevent complications in these cases. Thank you.
Yeah, am I audible?
Yes, sir.
Yeah, two good cases of inflammation, unless otherwise proved in a pediatric age, unilateral or bilateral lid swelling or mild proptosis, invariably it is inflammatory or infective. So the best way to reach the diagnosis is a simple CT scan without any contrast or an MRI. Okay, so these two will give you whether it is inflammatory or it is space occupying lesion. Right, and as you told, most common organism isolated is a Staph aureus.
Staph aureus.
Yeah, in most of the studies. And the origin of infection is the ethmoiditis. Right?
Yes.
And what precaution or what suggestion you would like to give to the mother who is the caretaker of the child?
Yes, sir. Yeah, to look out for frequent upper respiratory tract infections or any nasal blocks. And yeah, even for us, even at the beginning, starting of the infections, to get a proper medical care so that she can prevent any spread of infection like sinusitis or further complications.
Yeah, that's fine. Okay, we'll go to the next paper. Thanks.
Thank you, sir.
Dr. Yogita, are you there?
Yes, ma'am, I will join.
Okay.
Myself, Dr. Yogita Phadke, I am working as assistant professor in FGM Medical College, Aurangabad. I will be presenting clinical profile of rhinoorbital mucormycosis in COVID-19 patients. So as everyone knows, mucormycosis is an opportunistic, potentially lethal angioinvasive fungal infection. Although few cases of mucormycosis were reported during first wave of COVID-19 pandemic in India, a sudden surge of cases occurred during second wave. Severity of infection was seen in those associated with comorbidities like obesity, diabetes mellitus, hypertension, and COPD, etc. Systemic corticosteroids, which were being used in the management of COVID-19 lung involvement, have itself increased the incidence of diabetes mellitus in these patients. As cases started coming one after the other, we undertook this study after taking approval from institution's ethical committee. Clinically, patients of rhinoorbital mucormycosis presented with diminished visual acuity, diplopia, then proptosis, lid and periocular edema, ptosis, and impaired ocular motility. Most of our patients were referred from our ENT department colleagues for evaluation. So the aim of study is to study the clinical profile of rhinoorbital mucormycosis in COVID-19 patients. And objective was to identify risk factors associated with occurrence of mucormycosis and to study the resultant outcome in patients of COVID-19 rhinoorbital mucormycosis. So this study was a prospective cross-sectional study, and patients who are clinically diagnosed as having rhinoorbital mucormycosis during active COVID-19 infection or in post-COVID phase during second wave were included in this study at a tertiary care center in Marathwada region of Maharashtra. So the method consisted of all the patients underwent detailed ocular examination, including visual acuity assessment, pinhole vision, then the refraction, color vision, wherever possible, then proptosis evaluation, ocular motility evaluation, pupil evaluation, and dilated fundus examination. In all these patients, MRI brain with orbit with contrast was done, and the confirmation of diagnosis was done with nasal endoscopic sample or face sample. So the management included a team approach, including ENT consultants primarily, then physicians, radiologists, ophthalmologists, and maxillofacial surgeons. So periodic ocular evaluation was done that included visual acuity assessment, proptosis measurement, then ocular motility evaluation. So all this patient underwent 9-gaze photograph periodically, and then pupillary evaluation in every assessment. So observations included out of 208 patients, 163 patients were males and 45 patients were females, with main age group was between 41 to 60 years. History of COVID-19 infection was present in 193 patients and 15 patients had no history of COVID. 102 patients had received systemic steroids, and the patients, although some of the patients could tell how much dosage was given for how many days. 117 patients had required oxygen support during active infection. So in 90 patients had undergone face procedure, which was done by ENT colleagues, and repeated debridement was also done as per requirement. So out of 208 patients, 162 patients had comorbidities. Almost 49 patients had diabetes mellitus. 27% patients had diabetes along with hypertension, and then 17 patients had other history of other comorbidities, and 7% patients had history of thyroid disease. So mean duration of onset of mucor infection was 2 to 4 weeks after onset of COVID symptoms. 28 patients presented to us with who had either perception of light vision or no PL vision due to presence of central retinal artery occlusion or ophthalmic artery occlusion. So in the management included primarily systemic amphotericin injection. Mostly we tried to give liposomal, but if liposomal amphotericin B was not available, even lyophilized amphotericin B was also used. Along with systemic medication, the patients almost all patients underwent phase or some sort of debridement by ENT consultants. And then ocular management included giving transcutaneous amphotericin B injection and retrobulbar injection, along with few patients required exenteration. So, out of 36 patients who had been given transcutaneous retrobulbar amphotericin injection, 25 patients showed improvement in proptosis and ophthalmoplegia after giving this tram injection. Out of these, almost 15 patients received 3 injections, which we gave every alternate day. 0.8 cc or 3.5 milligram of amphotericin B was given by retrobulbar injection. And 6 patients required 5 injections of tram. So 31% patients showed no improvement even after giving maximum dosage of amphotericin B. So these are the few pictures which show this left side picture which shows proptosis along with ophthalmoplegia pre-injection, and then there was improvement in proptosis post-injection. So the total outcome was eye salvage along with preservation of vision was possible in 180 patients, and eye salvage without preservation of vision was seen in 17 patients, and exenteration was done in total of 11 patients. So this is my final table. So this shows 36 tram injections and 11 exenterations being done, and total number of deaths during the course of study were 45 amongst 208 patients. So mucormycosis being the potential lethal infection, the exact reason by the research of mucor cases during second wave of COVID-19 pandemic is not known, although different postulated mechanisms are like oxygen usage, usage of systemic steroids, all those were given later on. So diabetes mellitus, in my study, diabetes mellitus remains the most common comorbidity associated with it. So and prolonged use of ventilators was also, and like prolonged use of same mask or damp mask was also the prolonged postulated mechanism. So to conclude, mucormycosis was more commonly seen in COVID positive diabetic patients, and early detection and timely intervention in a multidisciplinary approach can definitely improve visual outcome and prevent mortality. Thank you.
Am I audible, Dr. Phadke?
Yes, sir.
Yeah. Myself, Dr. Shivayogi, and even I had an opportunity to see many patients during May, June, July. I'm an oculoplastic
Yes, sir.
surgeon.
After July, month of July, we have stopped getting new patients, sir. Only we were following up those patients, and most of the patients we are keeping a follow-up and with good results,
No,
whatever those patients were.
We used to get patients after July also.
Yeah.
We also had a series of around 80 patients in the civil hospital in Davangere, the government hospital. And the study which you have put up with 208 cases is quite interesting, and it is almost similar to our case. I have a question to you, madam. Which was the most common presenting symptom in your case series? The sign, rather, not symptoms.
Sir, was commonest.
Louder.
Total ophthalmoplegia. Patients presented with proptosis and total ophthalmoplegia.
Total ophthalmoplegia.
Proptosis along with.
Yeah. Proptosis. We had ptosis as a most common presenting sign along with proptosis. Okay. Yeah. Similar results. When you lift the lid, there was external ophthalmoplegia. Probably many cases presented like that.
Okay. So today also in my OPD, there is one patient who is a diabetic and presented.
Can you speak little louder? I'm not able to.
So today also in my OPD, one patient has presented in a similar way. We'll just have to investigate now.
One more question. You told you have done exenteration in 11 cases.
Yes, sir.
Do you have any recurrence in those 11 patients? And these
So
patients come up again with swelling and discharge, pain,
uh,
such symptoms.
only one patient had recurrence, but he died after that recurrence.
With
I think he
exenteration, post
he had
exenteration.
completed complete dosage schedule of systemic amphotericin B. In spite of that, he had recurrence in the orbit, and after readmission, he death occurred within 3 days.
Fine, fine. Thank you for the information.
Okay, sir.
We may
Thank you,
switch over
sir.
to next paper.
Yes.
Hello.
Yeah. Who is going to present next?
Hello. This is Tejaswini here. Can I
Go
go ahead with my presentation?
Actually, our STEM course
Can the previous speaker switch off the screen and switch off the audio?
Hello.
Dr. Sushma, are you there?
Hello.
Hello.
Hello. Am I audible?
Yes.
Audible.
Am I screen? Is my screen visible?
Yes.
Yeah. You are Tejaswini?
Yes, sir.
Efficacy of transcutaneous retrovalvular administration. Go ahead if you are ready.
Yes, sir. Yes, sir. Good afternoon to everyone. Topic of my paper presentation is efficacy of transcutaneous retrobulbar administration of liposomal amphotericin B in post-COVID ROCM. So as we all know, mucormycosis is a potentially lethal angioedema fungal infection. The increased incidence of ROCM in the setting of COVID-19 in India and elsewhere has become a matter of immediate concern. As we all know, ROCM, or rather called as COVID-associated mucormycosis, can be attributed to many factors, like associated comorbidities like diabetes or any chronic pulmonary obstructive disease, oxygen administration, immunocompromised conditions like any solid organ transplantation, or if they're on chronic immunosuppressive drugs, etc. So such individuals, such susceptible individuals develop fungal infections in the paranasal sinuses that can directly invade the orbit and brain. Mucormycosis is known to induce vascular thrombosis, resulting in poor penetration of systemic antifungals, thus making it very troublesome for us to treat. So currently there are no standard treatment guidelines, but the most widely accepted therapy includes parenteral antifungal therapy and surgical debridement of sinuses with orbital exentration, which is not only disfiguring to the patient, but also it is highly morbid to the patients. Injection of retrobulbar liposomal amphotericin B is an alternative approach where you can provide the drug locally, like local administration of drug is possible in this approach. However, the adjunct use of antifungal retrobulbar injections have not been extensively reviewed in treating sinoorbital infection, thus making it the sole purpose for to take up this study, with the aim in mind to assess the clinical outcome and response to TRAM in patients with post-COVID ROCM. So this is an interventional prospective study, which was done from the period starting from May 2021 to August 2021. And the study population included around 96 sites of post-COVID ROCM coming to our tertiary care center. So all these patients were under comprehensive multi-departmental evaluation, including ENT and Ophthal, and detailed ophthalmic examination was also included, along with laboratory investigations and radiological examinations. So based on all this, we categorize the patient into mild, moderate, and severe, after which 1 ml of 3.5 mg of liposomal amphotericin was administered. Coming to the preparation of the drug, so to a vial of 50 mg of liposomal amphotericin B, 10 ml of distilled water is added to make a concentration of 5 mg per ml. And 0.7 ml of this is withdrawn and diluted with 0.3 ml of 5% dextrose to finally get a concentration of 3.5 mg per ml. So the technique was prior informed consent of all patients were taken, and under all aseptic precautions, a 1.5 inch long 26 gauge needle was used to deliver this 1 ml of 3.5 mg of liposomal amphotericin B into the retrobulbar space. And we directed the injection towards the region of radiographic disease to the affected eyes. Like in case if we find more disease to be concentrated in the medial compartment, we gave a caruncular, medial caruncular. Whereas if it is inferior, through the inferior and superior likewise. After which gentle pressure was applied to the eyes and patients were observed for 5 minutes after injection to monitor for signs of orbital compartment syndrome and reassessed after 4 hours of the procedure. And patients received 3 doses of tram on alternative days and then were reassessed for the disease status. Repeat doses were considered and the maximum given were 7 in this study. So this is how it was administered. So coming to the results, a total of 96 eyes of patients were included in the study, out of which 33 were females and 63 were males. That is, there were more of males in the study. And 89 patients had unilateral, while only 7 patients had bilateral orbital involvement. And out of 96 eyes at presentation, 29 eyes had already a vision of PL negative, and 8 eyes had PL negative to hand movements, and 12 patients had hand movements to counting fingers 3 meters, and 47 patients had a vision of more than counting fingers 3 meters. So out of 96 eyes, 71 eyes received 3 doses, 22 eyes received 5 doses, and 3 eyes received less than 3 doses as they were lost to follow up. And the bilateral diseases were seen in 7 patients, and thus these patients received tram to both eyes. So out of 67 eyes with PL positive to more than counting fingers 3 meters, 4 eyes retained the same visual acuity. 6 patients were lost to follow up. 2 eyes showed improvement from PL positive to hand movements, and 5 eyes lost vision during the course, which can be due to disease progression itself. Coming to the improvement seen, out of all these patients, 68 patients were seen to have reduction in pain. 69 eyes had reduction in eyelid swelling. 12 eyes had improvement in ptosis. 10 eyes had decrease in proptosis. 16 eyes showed decrease in chemosis, and 17 eyes showed improvement in ocular motility. So finally, out of 20 eyes which we had categorized as mild disease, 14 eyes showed improvement out of those. And out of 42 eyes with moderate disease, 30 eyes showed improvement, good improvement, and 7 eyes showed minimal improvement, and 3 eyes were status quo, and 2 eyes showed worsening, which required surgical intervention. And out of 34 eyes with very severe disease, only 12 patients showed improvement, and it was very minimal. So as you can see, mild disease category had a better improvement, and moderate disease also had a better improvement when compared to the severe disease at presentation. Coming to the complications of tram, around 4 eyes developed swelling at the site of infection, which can be attributed to local inflammatory reaction due to the drug itself. And 2 eyes had worsening of vision and ocular motility following 3 doses. And 1 eye had retinal infiltrates near the optic disc, which regressed in size eventually. It can be basically attributed to the disease progression itself. And eventually, we saw improvement in these cases as well. 19 eyes developed transient orbital inflammation with decrease in chemosis and conjunctival congestion. Subsequent doses were withheld in such cases, and the schedule was restarted after resolution of the same, which was within a span of 36 hours. And in these cases, no alteration in IOP and vision were noted. And out of 37 eyes, patients with no vision, 10 patients were subjected to medial orbitotomy with debridement, and 12 patients underwent orbital excitation, and 4 patients succumbed to the disease. So coming to the discussion, in this study, we have basically categorized post-COVID ROCM patients based on clinical and radiological evidence into mild, moderate, and severe disease, as I told. And we have analyzed the effect of tram in these patients. Considering the demographics, our patient's age was ranging between 23 to 68 years, with a mean of 49.2 years, and showed a male preponderance. Patients with orbital involvement have a higher mortality than with sinus-only disease. And there have been reports that describe 3 main treatment options for orbital fungal infection, that is exenteration, conservative debridement with local irrigation, and transcutaneous retrobulbar injection of amphotericin B. Finally, to conclude, I would like to say that TRAMP is a very effective, economical, and time-saving procedure in patients with orbital mucor of mild to moderate severity mainly. It is especially useful to buy time in patients who need surgical intervention timely but cannot get due to high surgical load or cases in periphery or systemically unstable patients, as was the case in our center. Also, in early form of disease, it is actually a very effective mode of treatment to prevent disease progression as well as to cure it. To conclude, this study could be a guiding light to fellow ophthalmologists with limited experience of ROCM for better decision making and thus saving life and vision. These are my references. Thank you.
Yeah, that was a good presentation.
Thank you.
Dr. Shivayogi here.
Yes, sir.
One thing which highlighted in your case was the way you
Yes,
give
sir.
the tram.
Yes, sir. Yes.
Yeah, the tram should always be given with the CT. You should have the CT scan next to you.
Yes, sir. Yes, sir.
The maximum area of
Yes.
The infection, then direct the needle right at the
Yes,
area
sir.
of infection, which is most commonly the medial wall of the orbit, isn't it?
Yes, sir.
Superior and medial wall.
Superior and I had mentioned
in
that,
our
sir. Yes, sir.
Yeah. That's what I'm highlighting.
Okay, sir.
In
Okay,
our
sir. Okay.
study, if you take 100 patients, we had this lesion in the medial orbit in around 90% of the patients.
Yes.
Yeah, in advanced cases, like for example, around 5 to 10% of the cases, it was full of, or it was occupying full
Yes.
of the orbit.
Yes.
Yeah, so that is ideal way of giving the tram along with a CT scan.
Yes, sir.
Doctor, if I can ask you,
Yes, sir.
what was the incidence of tram before COVID-19?
Before COVID-19, it was almost zero, so we have never actually tried giving tram to any of the patients with mucor.
That's right. In the history, there were 2-3 cases. You can just say around 2 cases of tram.
Yes, sir. In the history, yes, sir. Around 2 to 3, yes.
Almost zero. We never had a thought of
yes.
This tram giving in mucormycosis.
Yes.
Mucormycosis was tackled with intravenous amphotericin B or else an exentration.
Surgery, yes.
Yeah. In your case, have you done any local debulking?
Yes, sir. In disease categories of moderate and severe cases, in those two categories, in spite of giving tram when there was no improvement seen, in such cases, we have gone ahead with debridement and few patients required exentration as well, sir.
Okay, fine. Thank you.
Yes, thank you.
We'll go to the next paper.
Dr. Sushmita, are you there? Hello. Dr. Sushma? Okay.
Am I audible?
Yes.
Can I present now?
Yes, you can present.
Is it sharing?
Yeah, it's visible.
Good afternoon to everyone. My presentation is on the cold for Phoenix, mucormycosis in the COVID-19 times. Purpose of the study is to compare whether treatment incorporating retrobulbar liposomal amphotericin B for rhinos orbital mucormycosis in ongoing COVID-19 time can reduce the risk of exentration compared with the treatment with intravenous liposomal amphotericin B without compromising the survival rate of the patient. Introduction. The tale goes in ancient Greek mythology that the phoenix, a long-living bird, is born again by rising from the ashes of its predecessor. Such is the tale of this pathogen, which in recent times has risen like the phoenix from the ashes. Like most of the monsters, a phoenix could also be killed by being shot with the cold. So the topic goes by the name the cold for phoenix. Rhino-orbital mucormycosis is a fungal infection of the orbital
The slides
tissue.
are not moving. Excuse me,
Hello?
the slides are not moving and it's not full screen.
Now, sir?
No,
No? Now?
no. Make it full screen and then go ahead. Now they are moving, but make it full screen.
Okay. Is it now, sir?
No,
Now?
ma'am, select slideshow.
Yeah. Like this. Is it visible now?
Yes, ma'am.
Okay.
Right.
Okay. Rhino-orbital mucormycosis is a fungal infection of the orbital tissues by a fungus mucor of the class Phygomycetes, order Mucorales. Mucormycosis is severe and often fatal acute fungal disease. The angio-invasive behavior of this fungus leads to thrombosis, tissue necrosis, and invasion of adjacent tissues, thereby minimizing the local availability of the systemic antifungals. And making aggressive surgical approaches is very necessary in these patients. When affecting the sinus, rhino-orbital cerebral mucormycosis can extend to the orbital tissues, increasing the risk of CNS involvement and even death. In such cases, exentration is commonly indicated. With unclear guidelines regarding the optimal timing for exentration, given this procedure's disfiguring outcome, alternative methods of the treatment should be considered in recent times as the COVID cases are increasing. A unique and potential globe-sparing approach is retrobulbar and antifungal injection. Method is, it is a retrospective institutional study carried out in the Department of Ophthalmology from March 2021 to June 2021. 23 patients of biopsy-proven mucormycosis and radiographic evidence of orbital involvement were enrolled in this study. 13 were in the group A and 10 were in the group B. Group A consists of patients who were treated with retrobulbar liposomal amphotericin B. Amphotericin B, and group B consists of patients who were treated with intravenous liposomal amphotericin B. The patients of group A who were treated with retrobulbar amphotericin B, 1 ml of 3 mg per kg per day of liposomal amphotericin B with an antecedent retrobulbar injection of anesthetic comprised of 2 ml of 2% lignocaine is given. Maximum dose we had given is 5 to this patient, alternative day. And group B patients were treated with intravenous liposomal amphotericin B 5 mg per kg per day, liposomal amphotericin B in 500 ml of dextrose 5 with 10 units of human insulin regular is given over 3 hours, and it is followed by intravenous micafungin, that is 6 mg per kg per day every 24 hours, and oral posaconazole 300 mg every 24 hours for a week was given. Results in this study, which included 23 patients of rhino-orbital mucormycosis, in which group A patients who were treated with retrobulbar amphotericin B and group B patients who were treated with intravenous amphotericin B. Out of 13 patients in group A, only 1 patient underwent exentration and patient survived post-exentration. And among the other 12 patients, 10 patients survived and 2 deceased. In group B, out of 10 patients, 4 patients were subjected to exentration, out of which 2 patients survived, and among other 6 patients without exentration, 5 patients survived. This is the chart. In this, the age group is given. Mean age group is 32 to 78. And first patient was a diabetic patient. He did not undergo exentration. His vision on admission was 660 and final visual outcome was 624. Group A patients were treated with retrobulbar injection. And second patient was 32 years age with no systemic illness. Exentration was not done, and visual outcome was same as admission and as after the dosage of injection also. Here, if we want to find out, 7th patient who was 62 years old, he was diabetic and hypertensive, and there was no exentration was done to this patient, but the patient deceased, and his vision was 660, and he showed CNS involvement due to this. And the 11th patient who was 78 years old, no systemic illness, He was also deceased, and his vision was 216, counting because 2 meters. And the exentration was carried out in the 8th patient, that is 70 years old. He was diabetic with CKD. Exentration was done, and the patient survived post exentration. This is group B patient. This first patient was 63 years old. He doesn't have any systemic illness. Exentration was done. This patient was on intravenous amphotericin B, and the vision on admission was 1/60. The second patient, the fourth patient, he was diabetic, and he was at the age of 66 years. Exentration was carried out with this patient, and patient deceased after exentration. And counting figures 2 meter was his vision during admission. And the ninth patient, he was hypertensive, and he was 38 years old, and exentration was carried out in this patient, and he was also deceased, and his vision was 3/60. Here in this study, what we can conclude is, in spite of systemic illness, hello, am I audible?
Yes.
Continue.
Hello.
Varshita,
Discussion.
continue.
Okay. Discussion. Mucormycosis is a potentially life-threatening condition which requires prompt recognition and treatment. Challenges in treating rhino-orbital cerebral mucormycosis due to its undergoing pathogenesis, in which endothelial cell damage leads to vascular thrombosis, decreasing the efficacy of systemic antifungals. In progressive orbital diseases, exentration may be recommended. However, there are no clear guidelines regarding optimal timing for exentration. Although potentially life-saving, exentration carries significant complication, including certain blindness, cosmetic disfigurement, and psychosocial trauma. Management of mucormycosis consists of immediate initiation of systemic antifungals. In the recent years, with the purpose of reducing mortality and the need for potentially disfiguring procedures such as exentration, several alternative or adjunctive treatment have been proposed, including modern antifungal medications, local antifungals, hyperbaric therapy, and the cautious debridement. In 1969, Fleckner and Goldstein reported 2 cases of rhino-orbital mucormycosis treated with both systemic and local irrigation of amphotericin B. Since then, the descriptions of local antifungal irrigations, both intra and post-operatively, have sporadically appeared in the medical literature. Liposomal amphotericin B is often the antifungal agent of choice due to its superior survival rates and the ability to achieve higher blood levels without the immediate nephrotoxic side effects commonly seen with the deoxycholate formulations. Intraorbital irrigation of amphotericin B, which is not yet routinely used in the management of this devastating and frequently fatal disease, is a modality that was found to be useful in all these studies. The use of this technique is recommended in all cases of rhino-orbital mucormycosis infection, except for cases in which the exentration is clearly indicated or when palliative therapy has been decided upon. Conclusion: rhino-orbital mucormycosis is best managed by immediate initiation of intravenous antifungals, reversing the patient's immunocompromised state. In the setting of progressive orbital disease, retrobulbar amphotericin B treatment should be considered as an option prior to exentration. In this study, patients who were treated with retrobulbar amphotericin B had a lower risk of disfiguring exentration without an apparent increase in the risk of mortality. And we need furthermore studies to conclude this. And these are my references. These are the studies which they have done with the retrobulbar injection past 1969, but due to rise in the COVID cases and mucormycosis cases, now these studies have found useful for us.
Can we go ahead with the next presentation?
Yes,
Who is
doctor.
presenting next?
Hello.
Yes, doctor. Hello.
Yeah.
Hello.
Who is presenting?
Pavitra.
Yes, sir.
Ocular manifestation post-COVID, no?
Post-COVID. Yeah,
Yes,
go
sir.
ahead.
I'm just sharing my slides.
Okay, go ahead.
Sir, my slides are visible?
Yes, yes, yes. Go ahead.
Good afternoon, everyone.
No. No.
Sir, it is visible?
Yes.
Good afternoon, everyone. I'm presenting a paper on study of ocular manifestation of post-COVID rhino-orbital cerebral mucormycosis at a tertiary care center. The chief author is Dr. Rajshekhar Dyabari.
No, it's not visible. Screen sharing is not.
Sir, just a minute, sir. I'll just see to it. So now it is visible?
No. You stop screen sharing and again do it. Do it again.
So now it's visible?
Yes, yes. Make it full screen and go ahead.
Yes, sir. Good afternoon, everyone. Presenting a paper on study of ocular manifestations of post-COVID rhino-orbital cerebral mucormycosis at a tertiary care center. Introduction: a coronavirus disease 2019 caused by severe acute respiratory syndrome coronavirus 2 has been associated with a wide range of opportunistic bacterial and fungal infections. A mucormycosis is an opportunistic fungal infection. It causes infarction and necrosis of the host tissues by invasion of the vasculature by the hyphae. So the clinical presentation is secondary to inhalation of the spores into the paranasal sinuses of a susceptible host. Predisposing factors or situations for mucormycosis are diabetes, systemic corticosteroids, neutropenia, hematological malignancies, stem cell transplant, or immunocompromised status. Coming to the common ophthalmic manifestations, it can be decreased in vision, proptosis and lid edema, external ophthalmoplegia, chemosis, frozen orbit, internal ophthalmoplegia, and retinal changes. Next, coming to the purpose of the study, it is to evaluate the spectrum of ophthalmic manifestations in post-COVID ROCM. Materials and methods: the study population, 116 cases of post-COVID ROCM was taken, and the study design, it is a cross-sectional descriptive study, and the study was conducted from the month of May 2021 to August 2021. After taking consent from the patient, history was taken about the onset of the symptoms, duration, associated comorbidities, a COVID-positive status, oxygen therapy, and the use of corticosteroids. And the ocular examination was done assessing the vision, proptosis, ptosis, lid edema, conjunctival chemosis, pupillary reaction, extraocular movements, and the fundus. And imaging was done, MRI orbit, brain, and the paranasal sinuses for assessing the extent of the disease. Next, coming to the results, out of the 250 cases of mucormycosis, 116 patients had ocular involvement, out of which 87 patients were male and 29 were female, and 57 patients were more than 50 years of age. Next, coming to the diabetic status, out of the 116 cases, 113 were diabetic. Among them, 69 patients were previously diabetic and 44 patients were newly detected, and 3 patients were non-diabetic. Next, coming to the visual acuity, 40 patients had PL negative vision, 15 patients had counting finger less than 3 meters, and 61 patients had counting finger more than 3 meters. Next, coming to the orbital signs, lid edema was seen in 56 cases, proptosis was seen in 48 patients, ptosis was seen in 80, chemosis was seen in 40 cases, congestion was seen in 46 cases, and 77 patients had extraocular movement restriction.
As a whole, cellulitis-like picture was seen in 6 patients, total ophthalmoplegia was seen in 35 patients, and incomplete ophthalmoplegia was seen in 42 cases. And next, coming to the other peculiar features, periocular and lid abscess was seen in 12 patients. 5 patients had skin eschar, 2 patients had scleral melt, and 2 patients had acute dacrocystitis, and 1 patient presented with granular uveitis. Next, coming to the fundus examination, 74 patients had a normal fundus and 13 patients had pale disc. Central retinal artery occlusion was seen in 6 patients. Disc edema was seen in 3 patients. Branch retinal vein occlusion in 2 patients. Retinal detachment was seen in 1 patient. And fundus was not visualized in 14 patients because among them 10 patients had hazy cornea and 4 patients had cataractous lens. Next, coming to the MRI finding, extracorneal fat straddling was seen in 54 patients. A retroorbital fat straddling was seen in 40 patients. Single compartment involvement was seen in 12 patients. Apex involvement was seen in 20 patients. Ischemic optic neuropathy was seen in 35 patients. Cavernous sinus thrombosis was seen in 5 patients. A cerebral abscess was seen in 8 patients. And brain infarct was seen in 8 patients. Next, coming to the discussion, COVID-19 associated mucormycosis posed us challenges with varied presentation. The conventional route is basically from the sinus, then to the orbit and to the brain, but orbit can be directly involved without much sinus involvement. In the surge of the COVID-19 associated mucormycosis cases, we as a tertiary care center had varied ophthalmic presentation, which had been discussed prior. And we concluded that mucormycosis, previously a rare disease which was restricted to immunocompromised status, became an epidemic under setting of second COVID-19 wave. Its varied presentation in such large numbers are worth compiling. Early recognition of these signs and symptoms would help all ophthalmologists to manage it efficiently. Thank you.
Thank you. Can we go to the next presenter, because the topics are same and there are no more questions. Okay, go ahead.
Am I audible?
Yes, yes, go ahead.
Yeah, audible.
Yes, thank you. Good afternoon all. Today I'm going to present on the rare lumps and bumps of the eyelid. No financial disclosure and consent has been taken for all the clinical photographs used in this presentation. The aim of the study is to report 2 cases of very rare benign eyelid lesions. The first case was of a 35-year-old female who presented with a progressively increasing painless growth on the right lower eyelid of 7 months duration. Best corrected visual acuity was 6.6 and she presented with a 3x3 millimeter sessile firm non-tender lesion in the middle 1/3 pass of lashes, and the posterior lid margin was normal. The patient underwent a wedge excision with histopathological examination. The histopathological examination revealed a dermis consisting of an unencapsulated lesion composed of plump, oval, or epithelioid to spindle cells in sheets, which was surrounded by thick hyalinized collagen bands, as seen in the figure in the slide, thereby confirming the diagnosis of myoepithelioma. The post-op period was uneventful, with no recurrences at 9 follow-up period. So this is the pre-op and the post-op pictures of the patient. So coming to the discussion, it is a rare epithelial tumor which presents in minor and major salivary glands composed of proliferating myoepithelial cells which lie between the basement membrane and the acinar epithelial cells of exocrine glands. That typically benign. Excision is curative. And I would like to highlight that only 9, that too in the lacrymal gland, and only one is reported in the lower eyelid, which is reported in literature. Sorry. So, for the diagnosis of myoepithelioma, the epithelial component should be less than 5% of the tumor to consider the diagnosis of a pure myoepithelioma. Fibromyxoma should be acceptable diagnosis, and myoepithelioma is derived from a single cell type as opposed to a pleomorphic adenoma, a monomorphic adenoma. There are 5 cellular variants which are described in ants, namely spindle, plasmacytoid, epithelial, clear, and mixed type. The current case is of the spindle type. So I would like to highlight that this is the first reported case to the author's best of knowledge of myoepithelioma of a spindle variant, and this is the first case to be reported in Asian population occurring in the periorbital region outside the lacrimal gland. Thus, I would like to conclude that the orbital surgeon should be aware of the existence of this rare adenoma subtype, its benign clinical course, and its association with the lacrimal gland tissues. Coming to the second case, this was a 36-year-old female who presented with a painless swelling of the left lower eyelid near the lateral canthus of 2 months duration. The best corrected visual acuity was 6.6 and on anterior segment examination revealed a 5x6 millimeter very subtle firm lesion, immobile horizontally on the left lower eyelid adjacent to the lateral canthus. It was more of a palpable lesion than that of an invisible lesion. There was no intraorbital extension which was confirmed on the computerized tomography of the orbit. The rest of the anterior segment and the fundus examination was within normal limits. So this is a very subtle lesion, and we can see that there is no intraorbital extension on orbital imaging. This patient underwent excisional biopsy. The histopathological examination revealed fibromuscular tissue with cysts lined with cuboidal cells and stratification and apical knots, thereby leading to the diagnosis of apocrine cystadenoma. The post-op period was uneventful, and there was no recurrence at 12-month follow-up period. So coming to the discussion, eyelid neoplasms that derive from apocrine glands include the common heterocystomas, which occur at the lash line and the canthi. And the rarer tumors include apocrine adenomas, carcinomas, and the current case, that is the apocrine cystadenoma. There is a lot of confusion in literature regarding the terminologic distinction between the apocrine heterocystomas and the apocrine cystadenomas. Apocrine cystadenomas are basically the mole gland tumors of the eyelid. There are no definitive clinical characteristics, and they are usually diagnosed pathologically by hematoxylin and eosin stain sections. So excision is curative. The principal diagnostic histopathological feature of apocrine is of apocrine glandular differentiation and the decapitation of secretion from the cuboidal cells having eosinophilic cytoplasm as seen in our case, and the distinct histopathological findings and further confirmation by immunohistochemistry studies leading to the giving rise to the positivity of cytokeratin 7 and GCDFP15, that is the apocrine differentiation marker, aids in the diagnosis of this rare benign eyelid lesion. Malignant transformation is very, very rare, and it often poses a clinical and histopathological diagnostic dilemma. So in conclusion, these two lesions are benign lesions which are very rare. The importance of excisional biopsy lies in the fact that it is curative and diagnostic. Characteristic HPE findings are diagnostic, and further research and studies with respect to the immunohistochemical studies aids in evolving a robust and a systemic nomenclature and classification system. Thereby, we become more and more aware of such rare benign eyelid lesions. Thank you. Thank you all for your kind attention.
Thank you, ma'am. Dr. Sushmita, are you there?
Dr. Santanu is ready. Dr. Santanu?
Hello. Yes, sir. Yes, sir. Can I share my screen?
Yeah. I think we can go ahead.
Yes, you can share.
Okay. Fine. I'm sharing. 1 second.
It's visible. Make it full screen and go ahead.
Yes, sir. Once. So my slides are visible.
Yes, Dr.
Yes.
Hello. Yes. Okay, sir. Okay. Good afternoon, everyone. I am Dr. Shantanu Das, and I'll be presenting on management of a long-standing case of facial nerve paralysis. So the ophthalmologist may be the first clinician to see a patient who presents with an acute or a chronic facial nerve palsy. So under such circumstances, the ophthalmologist should make every effort to establish the underlying cause of the palsy and should ensure that the patient's cornea is adequately protected. So a facial palsy can have devastating effect, starting from visual effects due to corneal exposure, visual defects due to corneal exposure, ocular pain or discomfort, chronic lacrimation and epiphora from corneal exposure, paralytic ectropion, cosmetic disfigurement, and difficulties with speech, and while talking there might be drooling of saliva. So I'll be presenting a case report where an elderly gentleman presented with a long-standing left-sided facial palsy. He had a medial and central paralytic ectropion, and he had a lateral canthal tendon dehiscence with medial canthal tendon laxity, left lower lid laxity, loss of forehead creases. There was brotosis on the left side. Restriction of brow lift was there on the left side. 7 to 8 mm of lag ophthalmos, 3 mm of inferior scleral show was there on the left side, and he had exposure keratopathy in the inferior 1/3 of the cornea. So the surgery that we planned is a lateral tarsal strip with a lower lid scleral patch graft and a posterior medial thermoplasty. So I'll play a small video. Yes. So first is the lateral tarsal strip. So we are giving a lateral canthotomy and inferior cantholysis. So we'll fashion the lateral tarsal strip. So upon fashioning the lateral tarsal strip, so we keep it like that. And so these are the ethipond sutures that are being passed through the tarsal strip. So these sutures will be ultimately anchored to the periosteum of the left-sided lateral orbital rim. So here we left it, and we proceeded with the scleral patch graft. So the dissection is being carried on along the inferior border of the lower tarsal plate. And so here we are doing the dissection to recess the inferior retractors and the conjunctiva complex. So the defect is being measured, and an adequately sized scleral patch graft has been fashioned, and it is being sutured into place using 6-0 Vicryl sutures in a continuous fashion to cover the defect. So next is the medial thermoplasty part. So next is the medial thermoplasty. So here cautery is being used. So we are putting circular burns. So in the medial canthal area, we are not damaging the caruncle as well as the punctum. So care must be taken not to damage the caruncle and the punctum. So the main principle is to make the dehisced Horner muscle come and reattach to the tarsal plate. So here 6-0 Vicryl sutures are being passed just lateral to the punctum, and through a firm tissue below the caruncle, we are taking a bite. So we are passing the suture below the caruncle through a firm tissue, and we will anchor it with a bolster. So here it is seen we are anchoring the suture with a bolster. We'll take a bolster and we'll anchor it. So next is we are completing the lateral tarsal strip. We are fixing it on the lateral orbital rim. We are fixing it to the periosteum, and then the wound will be closed in layers. So this is the pre-op picture where a lot of the lower lid height on the left side can be seen, which is below the right-sided lower lid. And this is post-op 2 weeks, where we can see the lower lid is at the level of the inferior limbus. And also, if you see the amount of lag ophthalmos that was there pre-op, which was around 7 to 8 mm, here we can see only around 2 mm of lag ophthalmos is left, and the cornea is getting fully covered. So posterior medial canthal thermoplasty, it works by creating a directed posterior lamellar scar. So the technique involves a posterior lamellar diathermy burn between the medial canthus and the medial end of the tarsal plate, sparing the canaliculus as well as the punctum. So it works on the principle of reattaching the dehisced Horner muscle to the tarsal plate. So this technique is simple and it is quick and it is minimally invasive. So without any external scar, the canaliculus and the lacrimal apparatus are preserved in this, unlike with medial canthal resection procedures. It induces more fibrosis than that can be potentially done with other procedures, and it causes less visible scarring or symblepharon. It is also simpler and less invasive than full thickness medial resection procedures. So this is the paper which has been published in OPRS, where they have used posterior medial canthal thermoplasty for various kinds of paralytic ectropions. And what they have found is the procedure has a very good outcome in the long term, and the patients reported a very good compliance to the procedure, as well as they had reduction in tearing and other cosmetic disfigurements that are caused by a facial nerve palsy, long-standing facial nerve palsy. So in conclusion, posterior medial canthal thermoplasty, it's a simple, safe and effective procedure, so which reduces the any scarring or any symblepharon. Thank you.
Yeah, your presentation is complete, Mr. Shantanu.
Hello, sir.
Your presentation is complete? You're done with presentation?
Is it over? Is it over?
Yes, sir. Yes, sir. It is over, sir. Huh. I can hear you, sir. Yes.
Dr. Sushmita? Dr. Sara? Dr. Sara? Are you there?
Santanu, you stop screen sharing.
Okay, sir. Okay.
Nice presentation. Thank you.
Okay, sir.
Dr. Sushmita? Are you there?
Who is presenting next?
Hello.
Yeah, Dr. Sara, you are there?
No, sir, this is Dr. Sushmita.
Sushmita.
Yeah, please go ahead.
To determine the prognosis.
Somebody else is sharing, sir, already. Hello?
Yeah.
Yes.
Am I audible, sir?
Yeah. Sushmita
Okay.
S, right?
Yes, sir.
Go ahead.
So this is Dr. Sushmita, and the paper number is FP1006. My paper is about a study which is done to determine the prognosis in patients with COVID-associated mucormycosis undergoing orbital exentration. Coming to introduction, mucormycosis is an uncommon, acute, potentially lethal angioinvasive fungal infection that is characterized by tissue infarction, necrosis. Rhino-orbitocerebral mucormycosis is the commonest form of the disease, followed by pulmonary and the cutaneous forms. It occurs due to fungal spore inhalation and direct trauma to nasal mucosa or sinuses, and then it takes a swiftly progressive course by spreading to the orbit and occasionally to the brain. Through the current pandemic of COVID-19, we saw an increase in the number of cases of COVID-associated mucormycosis. Diabetes mellitus is observed as the most common predisposing factor, followed by hematological malignancies and solid organ transplantation. Rhino-orbitocerebral mucormycosis can be subdivided into 3 types based on involvement, that is paranasal sinus involvement, rhino-orbital, and rhino-orbitocerebral involvement. Common symptoms include facial pain, proptosis, palatal or nasal ulcers with central necrosis, classically seen as a dark patch. Orbital involvement occurs when the infection invades the orbital wall from the paranasal sinuses. Symptoms may include pain, chemosis, vision loss, ophthalmoplegia, and proptosis. The overall survival rate in rhino-orbitocerebral mucormycosis is less than 50% and depends upon the progression and underlying comorbidities. In patients with cerebral involvement, the overall survival rate is less, that is 15%, while in the patients with just the rhino-orbital infection is approximately 50%. Coming to aim of the study, it is to determine the prognosis in patients with COVID-associated mucormycosis undergoing orbital accentration. Materials and methodology. It's a prospective observational study which was done from the inpatients with mucormycosis ward of a tertiary healthcare center. After obtaining approval and clearance from the institutional ethical committee, patients fulfilling inclusion criteria were enrolled for the study. Detailed history, general physical examination, followed by complete ophthalmological examination was done. On the basis of signs and symptoms, patients were divided into 3 grades, like in our study. Coming to mild grade, which included patients with periocular fullness, visual acuity of more than 4/60, and with brisk pupils. Moderate included patients with visual acuity of less than 3/60, with or without pupillary involvement, with or without mild to moderate ptosis, with or without proptosis, with or without incomplete ophthalmoplegia. Severe grade included visual acuity, which was no perception of light, dilated pupils, severe ptosis, proptosis, with or without incomplete ophthalmoplegia, and bilateral orbital involvement. MRI was done to rule out for any intracranial extension for all these patients. Patients with mild to moderate grade were subjected to trial of retroorbital amphotericin B injection, and the patients with severe grade were taken up for orbital accentration surgery in ally with FES under GA. Patients under the trial of retroorbital amphotericin injection who later worsened were also taken up for the surgery. Here is a picture of pre-op picture of one of our patients, and the picture status post accentration. Coming to results, in a study which was done by C. Fairley et al., it was found that orbital accentration and radical debridement of involved adjacent structures combined with intravenous liposomal amphotericin resulted in patient survival. In a study which was done by Roderick, it was found in orbital mucormycosis patients that accentration in patients with fever were more likely to survive compared to with non-accentrated patients with fever. In our study, a total of 348 cases of COVID-associated mucormycosis were considered. These included 192 patients who were COVID positive at that moment and 156 patients who were in post-COVID recovery at the time of diagnosis. Out of these, 203 patients were having ophthalmic involvement of any degree. 203 patients had ophthalmic involvement. 86 out of 203 patients had no perception of light vision, in whom 34 of them had intracranial involvement. 36 out of 86 patients, that is 44% of our patients who had no perception of light vision, underwent orbital accentration, and these patients were followed up for survival prognosis for 1 month period. Among the patients accentrated without intracranial extension, 26 out of 30 patients, that is 86.67 patients, survived after 1 month. And among those patients accentrated with intracranial extension, 4 out of 8 patients survived after 1 month, that is 50%. However, among 48 non-accentrated patients with no perception of light vision, 36 had extensive intracranial involvement and could not be, and hence were not considered for the surgery. And 12 other patients were not considered because they presented in a condition which deteriorated rapidly. Coming to conclusion, retroorbital cerebral mucormycosis being a rapidly progressive disease, even a slight delay in the diagnosis or appropriate management can have devastating implications on patient survival. However, the outcome can be optimized by early diagnosis, prompted by awareness of warning symptoms, signs, and a high index of clinical suspicion, confirmation of a diagnosis by appropriate modalities, and initiation of aggressive medical and surgical treatment by a multidisciplinary system. Although morbidity associated with accentration is high and necessitates further procedures to improve cosmetic outcomes, accentration is known to improve survival rates in such patients. The same has been seen in our study also. These are my references. Thank you.
Doctor, am I audible?
Sir.
I'm Dr. Shivayogi here.
Sir.
Your survival rate, you are depicted for 1 month for orbital disease is 44%, whereas for intracranial spread, it is 50%. Am I right?
Hello, sir.
The survival rate for an intraorbital disease is 44% according to your study, whereas for intracranial extension, it is 50%.
Andre, out of 8 patients, 4 of them survived. That is what I meant, sir, from 50%.
Have you followed these 4 patients after 1 month?
No.
Whether they are surviving still or there is a mortality among these 4?
Among these 4, sir?
Yeah,
they are alive, sir.
They are alive with intracranial extension.
Yes, sir.
That's a little, if the disease is in the brain, the survival rate is around 80 to 90%. The mortality rate, what I'm talking about. Whereas in your study, it is 50%. If the disease is in the orbit, 2/3 of the orbit or less than half of the orbit, the survival rate is around 45 to 50%.
Right, sir.
But that is same in many studies as in our study also. But if it is in the intracranial area, intracranial space involving the brain, the mortality is nearly 100%. Please remember, it's not 50%. Okay. So you need to check for those 4 patients who had intracranial extension, and then you can modify your study or whatever.
This was just for that 1 month period that what I presented, sir.
Yeah. You need to follow them, no? After 1 month.
Yeah, right, sir, right.
Yeah, 1 month is not a to say it at a study.
Right.
So you need to follow up them and whether they are surviving. That's very important.
Right.
Right. Okay. Thank you.
Thank you.
Dr. Pooja? Hello.
Yeah, next.
Dr. Pooja, are you there?
Out of 14 free papers, 12 are females. It's a point to be noted. Just for a comment.
Right. Ophthalmology is full of females, man, now. Anjali? Pana?
Yes, sir.
Pana is there? Anjali is there?
Yes, sir. Anjali is here, sir.
Are you ready, Anjali?
Yes, I'm ready, sir.
Please go ahead, no?
Can I go ahead, sir?
Yeah. Share the screen. She's getting ready.
Good afternoon, everyone. Myself, Dr. Anjali. I'll be presenting a paper on the management of active thyroid eye disease. Thyroid eye disease, as we all know, is a potentially sight-threatening ocular disease, most commonly occurring in patients with hyperthyroidism. The prevalence of TED...
1 minute, you are not shared the screen.
Sorry, sir?
Slides
you are not shared the screen.
Okay, 1 second. Now, sir?
Just starting.
Is it visible, sir?
Yes, make it more full screen and go ahead.
Yeah. Yes, sir.
Yeah, start.
Okay, I'll be presenting a paper on the management of active thyroid eye disease. So TED is a potentially sight-threatening ocular disease, most commonly occurring in patients with hyperthyroidism. The prevalence of thyroid eye disease among patients with thyroid dysfunction ranges from 51% in Caucasian population to 34% in the Asian population. The treatment should rely on the thorough assessment using the available scoring systems to assess the severity of the disease and its impact on patients' quality of life. Traditionally, steroid therapy and radiation therapy are the most commonly used modes of treatment of active thyroid eye disease. IV steroids are more effective and have a lower side effect burden compared to oral steroids, and thus are the preferred mode of administration. So the purpose of the study is to assess the outcomes in patients with thyroid eye disease who were treated with high-dose IV glucocorticoids. Methodology, it is a prospective interventional study. The records of 7 patients with a minimum follow-up period of 1 month have been included in the study.
In each case, informed consent was taken and history and ocular examination findings were documented. The clinical activity scoring was used to determine the disease activity at presentation. And patients were treated with 500 milligrams of IV methylprednisolone per week for 6 weeks, followed by 250 milligrams per week for another 6 weeks, for the total duration of 12 weeks. This is the Kahli's protocol. And patients were followed up at 1 month, and the clinical activity score was analyzed again at that point of time. I'll be presenting only one of the cases. This is the case of a 52-year-old male who presented with redness, pain, diminution of vision, and increased prominence of his right eye since 1 year. His best corrected visual acuity in the right eye was 6/24, and in the left eye, it was counting fingers 1 eye because he has a he had a senile immature cataract in his left eye. The Lude's exophthalmometer reading in the right eye was 21 millimeters, and in the left eye it was 17 millimeters. There was a restriction of extraocular movements in all this 9 cardinal gases, and his clinical activity score on presentation was 6/7. On 1 month follow-up after treatment, the patient's BCVA in the right eye decreased further to 6/36, and the Lude's reading was 24 millimeters with no improvement in extraocular movement restriction. He had developed RAPD grade 2, which was at that point, which was suggestive of compressive optic neuropathy. And his clinical activity score at 1 month follow-up was 8/10. MRI orbits was done further, and it confirmed optic nerve compression. The patient further underwent orbital decompression at an outside hospital, and he is currently doing well. The results of the study, out of the 7 patients, 4 were females and 3 were males, and 4 patients had bilateral involvement while 3 had only unilateral involvement. Among the 7 patients, 4 had inactive thyroid eye disease on 1 month follow-up after treatment completion with a clinical activity scores of less than 4/10. And out of the 3 patients whose clinical activity score remained high, that is more than or equal to 4/10 at the end of 1 month follow-up, 2 had no improvement in ocular signs from the presentation, while 1 patient had exacerbation of the symptoms, which is the case I presented. Exacerbation of symptoms with increase in proptosis, decrease in visual acuity, and development of compressive optic neuropathy. All patients who showed no disease activity, that is inactive thyroid eye disease on follow-up, showed improvement only in constitutional symptoms, while other parameters like proptosis and restricted ocular movements remained the same pre and post intervention. So from the study, the conclusion is that high-dose IV glucocorticoids are still the mainstay of treatment of thyroid eye disease, especially in developing countries like India due to their cost effectiveness. Although they are effective in controlling most of the constitutional symptoms such as erythema and chemosis associated with thyroid eye disease, they still have little or no proven efficacy in decreasing the more alarming signs associated with the disease such as proptosis and restricted ocular movements. Furthermore, glucocorticoids are also very short-acting, which leads to frequent relapses and worsening of the symptoms. So from the study, it is evident that the efficacy of high dose of IV glucocorticoids is limited in treating patients with active thyroid eye disease, as they have no role in reversing the damage already caused by the disease and a meager effect on controlling the disease progression. There are no financial disclosures associated, and these are my references. Thank you.
If I remember,
yes, sir.
You commented on the radiation.
Yes, sir.
Radiation treatment. Do we give radiation in India?
Sorry, sir?
Any idea? Do we have that treatment?
We have not treated any patient with radiation, sir, in our study.
In India, the radiation treatment for thyroid eye disease is not done. It's only restricted for Western world. In the
Okay,
US,
sir. Okay.
A lot of literature about the radiation.
Okay, sir. Okay.
Yeah. Fine. We'll move to the next paper.
Okay, sir. Thank you.
Hello.
Pooja, go ahead.
Yes, sir.
Please share your.
Yes, sir. Sir, is it visible, sir?
Yes, yes. Go ahead. Make it full screen.
Yes. Good afternoon, sir. My study is about ophthalmic manifestations in patients of invasive fungal rhinosinusitis. The chief author being Dr. Parsappa Bhadrapalli, and I'm the presentation author, Dr. Pujasi Bobby. Invasive fungal rhinosinusitis is a rare but often fatal disease Many fungal species have been found to cause IFRS, most commonly Aspergillus and Mucor. IFRS was on a rise during the second wave of COVID-19 pandemic and was most commonly involving Mucor species. Almost half of the patients developed orbital complications. It is a cross-sectional observational study conducted on 152 IFRS patients attending the tertiary care center from June 2021 to September 2021. The aim of the study is to describe the ophthalmic manifestations in the IFRS patients. All the patients with clinical or imaging or KOH-MOM suspected IFRS patients attending the tertiary care center were included in the study. Detailed history was taken. A bedside visual acuity testing was done. Fundus examination was done. The imaging of the paranasal sinus, orbit, and brain was done. KOH-MOM fungal culture and sensitivity was done. Excentration or orbital decompression or transcutaneous retrobulbar amphotericin B injection was given. Histopathological examination was done for the operated cases. In my study, majority of the cases presented with orbital cellulitis, that is 43.4%, and the other presentations being accentrated eye, ophthalmoplegia, periorbital and preseptal cellulitis. The posterior segment findings in 17.1% of the patients was CRAO. In one patient, we had seen hemorrhagic retinal detachment and 0.7% showing NPDR, and the rest 81.6% being normal. The visual acuity being PL negative in 12.5% of the patients. Counting fingers less than 3 meters in 25% of the patients, and counting fingers more than 3 meters in around 55% of the patients. The history of COVID-19 infection, the 63% of the patients were post-COVID, 9% of the patients were actively COVID during the suspicion of IFRS, and rest 28% of the patients were non-COVID. Out of these, 92% of the patients were non-vaccinated. Around 44.7% of the patients had received oxygen therapy, and 50% of the patients had received steroid therapy during the previous admission for COVID-19. KOH-MOM was positive for fungal hyphae in 36% of the patients. In the CT findings, the majority of the patients, that is 49.3% of the patients, were showing pansinusitis. Pansinusitis with orbital involvement was seen in 43.4% of the patients, and orbital and brain involvement along with pansinusitis was seen in the 7.2% of the patients. In the operated patients, histopathology showed mucormycosis in 74.15% of the cases and chronic non-specific inflammatory lesion in the rest 25.85% of the patients. The procedures that were done were FES from the ENT side. Retroorbital amphotericin B injection was given in 13.8% patients. 19.7% of them underwent orbital decompression and 9.2% of them underwent orbital excentration. Comparing with the study done by Ritu Arora, Ruchi Goyal et al., our sample size was much on the higher side, being 152. The mean age being 48 years, with the ranging from 10 to 76 years. The male is to female ratio was comparable, that is 4:1. The history of COVID infection being the recent COVID history was present in 63% of the patients, and active COVID cases were 9%. Steroid and oxygen therapy received was comparable with the comparative study, and 66.4% of our patients were diabetes, whereas in the comparative study, 98.33% of the patients were diabetic. The mean duration between the median duration between the confirmation of COVID-19 and detection of IFRS was 25 days in our study, with the ranging from 0 to 70 days. With 17 days in median duration in the comparative study, with 0 to 47 days. 7.9% of our patients had a history of vaccination, which is again comparable. The KOH-MOM was positive for fungal hyphae in 43.42% of our patients. The culture positive for mucor was only in 11.17% of our patients, whereas it was higher on the higher side, that is 42% of the patients in their study. And the mixed infection, that is mucor plus aspergillus, was seen in 2.63% of our patients and 10.52% of their patients. Patients with 23.68% of our patients showed aspergillus in the fungal growth, and candida was seen in 3.28%. Histopathological examination was significantly higher in our study, showing mucormycosis. The imaging showing orbital involvement was seen in around 50.65% of our patients. The ophthalmic findings were similar in both the studies. The conclusion, the ophthalmic involvement is a very common in IFRS patients, being 54.6% in our study. The new COVID-19 variant, diabetes mellitus, prior oxygen and steroid therapy probably were the most common risk factors. Although significant number of other species of the fungus were involved in the IFRS, mucormycosis was found to be the most common organism as per the histopathology report.
Yeah, if there are no questions, we'll move to next presentation. Sarah and Dr. Panna.
Sarah? Dr. Sarah, are you there?
Yeah, speak louder.
Hello, ma'am. Can you hear me, ma'am?
Yes.
Louder.
Ma'am, can you see my screen? Hello, sir, can you please see my screen?
I am not able to hear you, madam.
Screen, sir?
No. Somewhere the sound is coming. Something.
Yeah.
It's not quite audible.
Hello.
Little louder. Again, not audible.
Hello, sir.
Yeah.
Can my screen is getting shade, sir?
Yeah.
Am I audible, sir?
Hmm.
Okay, thank you, sir. I'll start my presentation. Good afternoon, sir. I'm going to present a case report of both eye congenital macrocystitis with lacrimal fistula with punctal aplasia. Coming to introduction, lacrimal dysfunction due to anatomical facial abnormalities in case of craniofacial syndromes may be due to soft tissue abnormalities such as lateral displacement of the medial canthus, primary telecanthus, aplasia, or displacement of the puncta, or due to underlying bony malformation such as maxillary hyperplasia, abnormal persistence of membrane, or bony narrowing at the distal end of the nasolacrimal duct. The membranous obstruction is a result of persistence of the distal lacrimal duct epithelium.
Excuse me, the slide is not being shared. Excuse me.
Yes, sir.
No slides.
No, sir.
No. The other judges being, can you see the slides? Anybody?
No, doctor.
No slides. They are not moving.
Slides are not there. Can you please put up your slide, please?
You stop screen sharing once and again do it once.
Now, sir?
No. First you stop. Now again you. Yes. Right. Now it is that your desktop listing is seen. Computer. Go to that folder and open it.
It's not visible, sir, still?
No, not visible. No, you have to stop screen sharing, then again go back. Now it's going. Yes. Go ahead. Double click. No. I think that folder has a problem. Do you have backup somewhere else? Don't close it. If you close it, it will only go there. Screen sharing should be stopped and again. Open it. Double click.
Make a double click on the folder.
Pana is there? One more presenter, Pana.
Yes, sir.
Pana, we can try. Madam, you stop screen sharing now. Tara. Yeah. Pana, you share the screen.
Yes, sir, I'll share my screen.
You go ahead. Tara will. Go ahead, please.
Yes, it's just opening, sir. So is the screen visible?
Only that your computer, desktop or computer screen.
Sir, the PPT is not visible. Okay, sir.
Folders are visible.
Okay, sir. Now, sir?
Yes, make it full screen.
Okay, sir. Is it full screen, sir?
Okay, it's okay. Go ahead.
Yes, sir. Good afternoon to everyone. Today, I'll be presenting on orbital aspergillosis, a rising concern in Kolar district, a retrospective observational study. Introduction. Rhinoorbital fungal infections, as we all know, are rare diseases seen in immunocompromised and suppressed individuals due to deficient phagocytic capability. It is mainly caused by Aspergillus and Mucorales species. Coming to Aspergillus, it is a filamentous pore-producing fungi which enter our body through the inhalational route and get deposited in the nasal mucosa where they germinate and produce hyphae that extend into the paranasal sinuses and then into the orbit and into the intracranial spaces. The incidence of these opportunistic infections has increased since COVID-19 pandemic, which is causing a surge in these fungal infections. Majority of suspected cases of rhinoorbital fungal infections were caused by Mucorales species. But at the same time, we also observed that some of the same features of rhinoorbital mucormycosis were confirmed species of aspergillosis. Hence, this study aims at identifying the increasing proportion of orbital aspergillosis in suspected cases of rhinoorbital fungal infections. My objectives are to determine the proportion of orbital aspergillosis in suspected cases of rhinoorbital invasive fungal infections and to identify the clinical presentation and risk factors for orbital extension of aspergillosis. Materials and methods. My study design is a retrospective observational study, and the study population included are the suspected cases of rhinoorbital infections admitted in our hospital between the period of 1st of April to September 2021 on the basis of clinical findings, radiological, endoscopic, and microbiological tests that were done. Detailed study, detailed history, examination, and confirmed information about the organism causing the disease were collected from the hospital, and an informed consent is taken from the patient for the above study. Inclusion criteria. Suspected cases of rhinoorbital fungal infection admitted in the period of 1st of April to 1st of September 2021 on the basis of clinical presentation, radiological findings, microbiological findings, and endoscopic findings. And the prevailing chronic diseases like diabetes, hypertension, liver diseases, malignancies, COPD, kidney diseases, and other systemic diseases were included. Exclusion criteria were the cases with no orbital involvement, only the sinus and the parasinal involvement, and the cases diagnosed and treated for invasive fungal infections before the period of 1st of May. Results. I had seen in my study that the males were more commonly affected than females. In my study, I had seen that the prevalence of this aspergillosis was 17.78%. That is, a total number of suspected rhinoorbital cases were 90. out of which the aspergillosis cases was 16 and the percentage had come as 17.78. The male to female ratio was 2.2:1 and the mean age of affection was seen in 49.8 years. That was seen that is in a younger age group was more prone to having aspergillosis than mucormycosis. Similarly, I have shown it in the table in the chart that there were 11 males that were affected out of 16 and 5 females. And the risk factors, mainly the risk factors that I included were the chronic systemic illnesses that could decrease your immune chemistry and other occupational diseases, which could also hamper in getting aspergillosis. So diabetes mellitus was seen as one of the main risk factors with 87.50%. And the patients out of 16 patients, they were seen that 56.25% of patients had COVID-19, a history of COVID-19, or they were currently admitted in the hospital with the COVID-19. 18.75% of patients were seen to be affected with hypertension, 50% of patients being chronic smokers, and steroid intake was seen in 46.15% of patients as a treatment as COVID-19 itself. And occupation wise, we had seen that 31% of the 31% of the patients were agriculturists, and some 55 patients were housewives, which included 30%, and rest all were other outdoor works. Clinical presentation that was seen, most common presentation that was seen in my study was periorbital swelling and pain that amounted to 12.
Or not moving.
Oh, okay. So 1 second. Is it now moving, sir?
No.
At least in my computer is not moving. The first page only
No,
was
it's not moving.
Okay, okay, sir.
And I wanted to comment because
I'll just start.
Make it fast. Make it fast.
Yes, sir. Now, sir?
Yeah, now it's
okay, sir. Okay. Coming to the clinical presentation, the most common presentation that was seen in my study was periorbital swelling and pain. That was 12 cases out of 16 patients had periorbital swelling and pain. 4 patients presented with chemosis. 11 patients with extraocular movement restrictions, that is total ophthalmoplegia. 5 patients with diminution of vision, that is PL negative itself. 9 patients with pupil abnormalities, that is RAPD grade 1, 2, 3. And 6 patients presented with CRO. There was no difference in CRO of mucormycosis or the normal CRO that we see usually with these patients. The age distribution that I tabulated is 5 patients were seen in 31 to 40 years of age group. 2 patients in the age group of 41 to 50. In the age group of 51 to 60, there were 4 patients. 61 to 70, there was 3 patients, and 70 to 80, there were 2 patients, showing that the younger age group was more affected towards aspergillosis. The most common presenting sign was again seen as periorbital edema and periorbital tenderness. And the most common feature on CT scan for these patients was seen as maxillary sinus mucosal thickening. Mortality rate was seen as 12.5%, and the remission of symptoms was seen in 56.25% of cases. Conclusion: orbital aspergillosis is seen to be strongly associated with COVID-19 infection, and patients less than 50 years are more susceptible to aspergillosis. Majority of males are more affected with the previous history of diabetes mellitus or newly detected diabetes mellitus after the infection of COVID-19. And risk factors of aspergillosis were almost similar to that of mucormycosis. In outdoor workers, more risk was seen when compared to the indoor workers, that is housewives. There was less risk when compared to the outdoor workers. The disease is seen to spread rapidly involving the ocular tissue, which causes the proptosis, ptosis, restricted movements, and blindness. Hence, it is important to diagnose the infection rapidly and treat it with utmost urgency. Thank you.
Thank you.
Shall we move on to the next presentation?
Sarah, last one.
Last.
Are you there?
Is it ready?
Sara, are you there? Please go ahead.
She's having
not
the
opening.
issue, same issue.
Do you have this folder in backup or something like that?
Dr. Sara?
Hello.
Dr. Sara, are you there?
Dr. Sir?
Sara? Madam, shall we wind up?
Yes, doctor.
In case the time is not permitting.
Okay.
Dr. Sara, I'll just ask her last time. Dr.
Okay.
Sara? Dr. Sara, are you there?
You are muted. Sara, you are muted. First you unmute.
Yeah,
It's open now.
Open. Make it fast, Dr. Sara.
Hello, sir. Is it visible, sir?
Yeah.
Visible. Please go ahead.
Make it fast.
Okay, sir. Sir, I am going to present a case report of both eye congenital dacrocystitis with lacrimal fistula with punctal aplasia. I'm audible now, sir?
Yeah.
Coming to introduction, lacrimal dysfunction due to anatomical facial abnormalities in cases of craniofacial syndrome may be due to soft tissue abnormalities such as lateral displacement of the medial canthine, primary telecanthus, aplasia or displacement of the puncta, or due to underlying bony malformations such as maxillary hyperplasia, abnormal persistence of membrane, or bony narrowing at the distal end of the nasolacrimal duct. The membranous obstruction is a result of persistence epithelium. Also develop secondary to chronic macrocystitis resulting from failed or non-canalization of nasolacrimal. All this requires high resolution childhood, also associated with redness and itching, poorly built, hyperplasia, with scarring and multiple fistulae in the lacrimal sac region. Applying pressure over the sac area through the sinuses. Upper punctum, aplasia of the lower punctum. Absence of lower canal.
Doctor, you are not audible. Hello. You are not audible, madam. What you are speaking is not audible to us. Can you no. Can you put up the picture? That is the 10th slide.
Yes, sir.
Can you put that picture? Yes.
Is it audible now, sir?
No. It's still breaking. Anyway, can you explain what you are doing here?
And we did dacrocystorhinostomy, sir, and silicone tube was put under general anesthesia, and the tube was planned to remove after 3 months. Sir.
Your paper is on congenital dacrocystis, right?
Yes, sir.
So what we are seeing is not a congenital dacrocystis, is it?
Sir, it was dacrocystis with the lacrimal fistula.
Anyway, can you come to the conclusion? Yes,
sir.
Yeah, discussion. Yeah.
Sir, it's underlines punctoplasty with canalicular construction and second stage of surgery was correction of lower lid after 3 months. Developed mild preseptal cellulitis around topical and systemic antibiotic discussion anomalies is syndromic. Many times they are also associated with dysphagia. There may be associated genitourinary anomalies along manifested at delayed developmental milestone without any intellectual deficiency. We had predominant Edmondson anomaly. We were able to achieve some success surgically. Otherwise, these cases required multidisciplinary approach. Some reference references.
Yeah, thank you. I think it's time to wind up. I think we have finished with all the papers. Thank you, Karnataka Ophthalmic Society and the scientific committee chairman for appointing us as the judges for this session. I thank the co-judges, Dr. Shivaji Padamukhi from Ilkal and Dr. Ravi Kulkarni from Ranebennur for participating in this session as judges. Thank you so much.
Thank you. Thank you all. Thank you. Bye-bye.
Madam, can we
Thank
wind
you,
up the
Alok.
session?
Yes, doctor.
Yeah, thank you so much.
Thank you.